Good afternoon, respected professor and distinguished guests. My name is Thanwala Tilakul, first-year fellowship from Rajvi Hospital. I'm pleased to present our case. Our patient is 40 years old woman from Nakhon Ratchasima. Her medical coverage is state enterprise officer. She came to our hospital for referral to treatment, persistent cervical cancer. 9 months ago, she came to Mahara Nakhon Ratchasima Hospital due to meteorological symptoms. Her pelvic examination shows cervical mass about 4 cm in both whole cervix and upper 1/3 of vagina at light parametrium, but not extend to both pelvic sidewall. Her cervical biopsy was done from this examination, and the pathological result is clear cell adenocarcinoma of cervix. So she was diagnosed as cervical cancer stage 2B. She was treated with concurrent chemoradiation with weekly cisplatin. The treatment was complete in 6 weeks. Her pelvic examination at 3 months after complete treatment. Her septic attachment was done, so cervical vaginal mass was still palpated. Then repeat cervical biopsy was done, and the pathological results still show clear cell adenocarcinoma. So she was diagnosed persistent cervical cancer and referred to Rajvi Hospital for further treatment. About her past history, she denied underlying disease, history of smoking and alcohol drinking. She also denied any previous surgery. No any family member had genetic disease and history of cancer. She didn't have any child. She got married and sexually active. No any hormonal use before. Her first menstrual period was at 13 years old with regular cycle. She denied history of abnormal uterine bleeding before this illness and no dysmenorrhea. Her physical examination, she is fully active, well-performant, and stable vital sign. No pelvic and abdominal mass was palpated. About her pelvic examination, she still had infiltrative mass at upper rib of uterine cervix with a regular discrete nodular lesion involving upper 1/3 of anterior wall of vagina, measuring about 2 by 2 cm, and also had indurations of right parametrium. She was repeated cervical biopsy and endocervical curettage in this. The result still was clear cell adenocarcinoma, and the endocervical curettage results was presence of residual adenocarcinoma. Then her diagnosis was persistent clear cell adenocarcinoma initial 2B. This slide will show her illness timeline. She started illness at February 2020. Diagnosis cervical cancer stage 2B. At June 2020 is complete CCR3 first treatment. About October 2020, she diagnosed as persistent cervical cancer and then referral to our schedule in November 2020. For further investigation in this case, MRI whole abdomen show markedly decreased infiltrative lesion, remaining tissue about 4 by 6 mm. Still suspect minimal bilateral parametrial flat stranding, multiple intra-abdominal and pelvic nodes up to 9 mm. Other abdominal organ and pelvic organ are normal. About chest X-ray, it's no active chest disease and evidence of metastasis. From all imaging and all evidence, no evidence of distant metastasis and pelvic sidewall involvement. So we decide plan of treatment as surgical treatment. We plan to do bilateral pelvic rim node dissection first, then central frozen section. If the result of frozen section is no malignancy, we will continue to do pelvic excenteration operation. The operation was started at 8 December 2020. The intraoperative finding is smooth surface of liver, spleen, and diaphragm, minimal lobus ascites, normal appearance of omentum, smooth bladder and rectum serosa. Bilateral pelvic rim node and para-aortic rim node were not enlarged. And normal uterus and both annexa with small subserous myeloma size about 1 cm. And infiltrative tumor at anterior cervical ribs extend to lateral fornix and upper 1/3 posterior vaginal wall area about 2 by 2 cm. Bilateral pelvic lymph node dissection is request for further section in this operation, and then the result is negative. So anterior pelvic exsanteration inferior operations were done, and Harvest transverse colon for conduit and end-to-end anastomosis was done, and appendectomy. These are the picture of gloss tissue. Pathologic report from this procedure. At cervix and lower uterine segment, there are several scattered foci ranging from 1 to 9 mm and occupy less than 5% of cervix and lower uterine segment. Tumor stromal variation are depth about 8 mm, horizontal about 9 mm, and no LVSI. There are free or recession margin from tumor involvement. Other tissue recessions were normal. All the second lymph nodes were normal. From this procedure, total operative time is 8 hours with estimated loss about 2,000 milliliters. Total length of stay in this hospital is 23 days. No serious complication during this admission. First follow-up visit was 2 weeks after discharge from hospital. She was looked well, good surgical wound and normal functions of conduit. She was advised for further plan to do PET-CT scan to be the guidance about adjuvant treatment decisions or observation. The results of PET and CT scan. There are several sub-centimeter intra-abdominal node metastasis or a possible differential diagnosis with reactive node. The slider arrow sign in the picture. And it's about the hypermetabolic foci beneath the surgical incisions are seen. Post-operative change with compensating tumor cannot be excluded. Conclusion, her diagnosis is persistent cervical cancer, initial stage 2B, clear cell carcinoma, status post CCRT with weakly cisplatin and anterior pelvic exsanteration with transverse colon conduit. The last follow-up is post-operation for 2 months. She is good well-being and normal function of conduit. The further plan in this patient is follow-up PET-CT scan next 3 months. Next, I will small talk about the pelvic exsanteration. What is exsanteration? It is a type 5 of pyruvate misclassification that will unblock resistance of female reproductive organ, lower urinary tract, and the portions of the sigmoid colon. Pelvic exsanteration is the only hope for complete cure in women with isolated recurrent malignancy in central pelvic after radiation treatment. The indication of this procedure are recurrent or persistent cancer of cervix after radiation therapy. The contraindication of this procedure are the pathognomonic of unresectable disease that they will show pelvic side wall involvement, including with unilateral leg edema, sciatic pain, urethral obstruction, and extrapelvic disease. About the patient selection, it must be considered about this specific indication, pharmacological issue, medical evaluation, laboratory and imaging tests, and the age. The patient that is more than 65 years will be increased moderately late. This is from the NCCN guideline. The indication of procedure is prior radiation therapy with central disease. The imaging that will detect metastasis lesions and will help to guidance the procedure is PET-CT is the best as shown in this study. Metastatic lesion that will preoperative imaging with PET-CT is has sensitivity about 92%. Comparable with MRI is about 60%. The p-value is 0.0003. And this paper, the systemic review of the study from 1961 to 2011 showed the cervical survival rates for patients following exsanteration for cervical cancer. The 5-year overall survival is about 24.7% to 64%. It had a few papers that studied pelvic exsanteration in clear cell carcinoma of cervix. At this paper, 5-year-old survival was 100% and 8-year was 60%. Anyway, in this paper, the number of clear cell carcinoma patients that undergone pelvic exsanteration was only 8 patients, so it might be limited point in this study. This next paper is shown the study that comparable pelvic exsanteration procedure in squamous cell carcinoma versus adenocarcinoma of cervix. There was no statistical difference in survival outcome. And the next paper is about the quality of life of patients after pelvic exsanteration. This paper was studied in Rajwiti Hospital. Study about quality of life in patients undergone pelvic exsanteration comparable with healthy women. This study was used functional assessments of cancer therapy cervical cancer questionnaire to assess. From this study showed that the quality of life in patients after pelvic exsanteration procedure not different from healthy women. Finally, the mortality rate of pelvic exsanteration was decreased year by year due to the development of operation technique. But the data this was a little and was too old and had a few papers that study about this. I hope in the future there would be more further research about the mortality rate and the pelvic exsanteration will be the choice to treat in the central recurrence of cervical cancer. I would like to express to sincere all the audience and thank you for your attention. Thank you.
Thank you very much, Dr. Thanwarat from Rajwiti Hospital that have presented us the quite interesting case and show us the specimen from pelvic exsanteration that in some hospital have never have the experience, and it is also in even though the uncommon case of the adenocarcinoma of cervix, especially for the clear cell carcinoma. Is some question from Ajahn Mongkol? Please, Ajahn Mongkol.
Okay, can you hear me?
Yes.
Oh, okay. You should pelvic exsanteration is a difficult procedure and invades a lot, so we have to make sure that it is for the curative intent, as you said. But may I ask you one question? That the evidence you show us that the good outcome for the recurrent cervical cancer, but this case is a persistent cervical cancer. So far as we know that the pelvic exsanteration is for the recurrent disease, local regional disease, and the longer the disease-free interval, the better the outcome. But this case is a persistent cancer. So do you have the evidence for the outcome of the exsanteration for the persistent cervical cancer?
Do you understand the question from Ajahn Mongkol? That could you show the difference between the case of persistent, not recurrence?
Because the guideline is about the recurrent, and the field paper that study in clear cell adenocarcinoma of cervix is very few and very old. So I think it's only the old paper. In this paper, it's about the 5-year rate, 100%. But this paper was done in persistent. But I think this paper will limit with the population because this paper showed that it had only 8 patients to do. The survival is 100%. It may be the limited. So we don't have newer research or study to show about the survival rate now. But I think in this patient, the patient was very fit, and I think we can resectable to free margin of all disease, and she is a central pelvic disease, pelvic disease persistent, so central cervic disease, sorry. it will be the good candidate to do this operation.
Okay.
One more question. Since this procedure, before doing the surgery for the pelvic extension, we have to the prerequisite criteria before the surgery, such as we have to rule out the any metastasis before doing this procedure. I am wondering about the PET scan. Why did you not do the PET scan before the surgery, but you did it after the surgery? Any reason for that?
Do you have a question? I do emphasize that Ajahn Mongkol said because in nowadays from universal coverage, สปสช that have provide the recommendation and suggestion that anyone that you plan to do the extension, firstly you must do the PET scan, and that the สปสช provide this for investigation.